What is testosterone replacement therapy, and how do you diagnose someone's symptoms as needing testosterone therapy?
We run a clinic called the Optimum Clinic, and guys come to us not because we've advertised, but because they're listening to podcasts from States, guys like Joe Rogan. So the common symptoms are feeling tired, erectile dysfunction sometimes, but low libido is a common one. Decreased muscle mass, low motivation to train, slightly low mood or anxiety, and poor sleep. Pfizer did a study a long time ago about systemic blood pressure, and they thought if we give something that'll dilate the vessels, that'll decrease the pressure. They gave them huge dose, 800 milligrams of sildenafil. It worked, but not fantastic. But they noticed that the packs from the placebo arm were being sent back, but the packs from the active treatment arm with sildenafil or Viagra in it weren't being sent back. And the reason was they were having fantastic...
Raging boners.
Right, they were having fantastic erections. Okay. And then they dialed back the dose a bit, and that's how Viagra was born.
Do you know that it's also good for period pain, but they just never pursued that avenue?
That's really interesting.
Yeah. Prostate. Can we talk a little bit about that?
How many guys put off going to see the doc for a prostate check because they know they might get an exam? If you're a man and you're alive, you should get your prostate checked. If you ask me, the number one diagnosis I'm making guys who are tired all the time, it's obstructive sleep apnea. The thing about sleep apnea is every minute you have it, you're taking minutes off your life. 9% of patients have Peyronies disease.
No.
I went through medical school, I didn't know what it was. So it's where you get trauma. Now, sexist trauma. What if you've got a little bit of erectile dysfunction? You're more likely to get trauma. They'll get a little bit of damage. What happens with damage? You get scarring. When you get scarring, you get a plaque build up. And the next thing now, your penis that used to be fairly straight is now starting to curve up or to the side. Once it goes to 60%, they can't get penetration. So now it's a disfigurement. And how likely are these guys to present to doctors? Even less likely. But there's great treatments out there.
But there's always a few ladies that say my husband has ED and won't do anything about it, or
Okay.
I haven't had sex in 5 years and
God
he won't
bless
talk about it. And yeah,
Right.
there's plenty
Okay.
of men out there that aren't speaking to their partners. Actually, I didn't think it was a size 50%.
Well, 50% will go to their GP, 50% won't,
Okay.
or a doctor, and then 44% won't tell their partner, 60% will.
Oh, okay.
Yeah,
Okay.
yeah.
Welcome back to the Laura Dowling Experience podcast. My guest today is Dr. Martin O'Rourke, a Dublin-based GP with a special interest in men's health. He's been practicing medicine for over 20 years. Is that correct?
In around.
Combining his expertise in general practice with a passion for addressing the often overlooked physical and mental health challenges faced by men. Dr. O'Rourke is a strong advocate for preventative care, early intervention and open conversations around men's health issues. From hormonal changes and prostate health to mental well-being and lifestyle management. He's well known for his practical, compassionate approach, making these important topics very accessible and easy to understand. And actually, I heard Martin speak twice actually in a couple of pharmacy schools over the years. You were speaking more about anxiety and your GP practice back then, but I'm delighted to have you on the podcast today talking about a subject that's actually often overlooked. It is, isn't it? Men's health.
Men's health, yeah. I mean, it certainly is. I would say I've been practicing a while now and went through all my medical school training, all my GP school training, all my hospital training, and you get taught very little about men's health. Now, there's two reasons for that. One, men don't look for it, so therefore it's not on the syllabus. And then we get taught very little about sexual health and definitely very little about male sexual health. So you can go through all your medical school training and GP training, end up as a GP and have very little knowledge. Now, lots of GPs do, but that was the case for me. I came out of medical school and out of GP school and I wouldn't have known much. Nobody's fault, but that was the way it was. So I would say I know a bit now. I wouldn't say I'm an expert, but I have a real interest in it. I think there's very few experts around unless they're doing loads of research and that themselves. But so I have a real interest in it, and it is a very kind of popular topic now, I think, amongst men to talk about men's health, and men will be interested to talk about sexual health generally, but it depends on their age.
And did this interest come about from you were practicing GP and the men were coming into you, or what? How did it come about?
Yeah. So my story is a little bit different in that I grew up in East Galway, very proud Galway man. And
You have the Galway socks on as well. I may have to kick you out of the studio.
Yeah. You can't take the Galway out of the man. So, so I grew up in Galway and I wouldn't have been a great student, I think. My mother always says, GC's the biggest surprise of all. And but I didn't know how to study. I stopped going to school when I was, I'd say probably February of my Leaving Cert year. Sat my Leaving Cert without ever having read the novel or the play that was on the English honours paper. I still did grand, but you're never going to do amazing by doing silly things like that. So I ended up doing science down in UCC, and then I learned how to study there, kind of sink or swim stuff. And then I ended up working in pharma. I wanted to be in the medical department. They said, you'd have to do a PhD, Martin. And I said, well, now, will I? And I decided to do medicine instead. And your question was, where did the men's health come out of? Well, I qualified as a GP, started work as a GP in Rialto, which is in Dublin 8, which is it's a change in demographic now, but it wasn't there that I got my men's health exposure. I work with guys in Rialto who had seen other GPs burn out in that practice, and they really just wanted me to work 3 days a week, and I needed 2 more days. And my friend had just come back from America, learned to be a vasectomist, and he met a guy who was selling his business, and as part of that business he had 50 or 60 guys on a thing called testosterone therapy. And my first line out of my mouth was, is that not illegal? So that was my starting point. Humble beginnings, Laura.
Okay. So testosterone therapy, that's the first thing you brought up. And that's the thing that people are very interested in when it comes to men's health.
Yeah.
So I hear all the time low T,
Yeah. It's as common as Barry's tea or any other tea talking about it these days. Yeah.
So what does it mean? Is every man low T? Do they all need replacement therapy? What is testosterone replacement therapy, and how do you diagnose someone's symptoms as needing testosterone therapy?
We run a clinic called the Optiman Clinic, and guys come to us not because we've advertised, but because they're listening to podcasts from States, guys like Joe Rogan talking about testosterone, or T as you put it, and they come wondering, are they low? So you're dead right. How do you know somebody might be low? Well, the common symptoms are fairly generic. They could be anything, right? And often guys end up being diagnosed with things like depression, fibromyalgia, chronic fatigue syndrome, being moody or whatever. So the common symptoms are feeling tired, erectile dysfunction sometimes, but low libido is a common one. Decreased muscle mass, low motivation to train, slightly low mood or anxiety, and poor sleep. And they're the symptoms, but they could be a lot of things, couldn't they? Mm-hmm. They're common enough symptoms across a lot of fields. And the thing in the clinic is to tease it out and to see, are they truly low? So if you've got symptoms and you have a low reading of testosterone, and we'll talk about free and total testosterone in a minute just to explain, then it's reasonable after making a decision with the patient to give somebody a trial, a treatment. And if it helps their symptoms, fantastic. If it doesn't, well, we need to look at other causes.
Okay.
But obviously you try and rule out other causes first.
So you don't go straight in there with the T?
We wouldn't be a clinic that would do that, right? So, and generally, guys won't come to me for that kind of a maneuver. They go to their gym. So it's no harm, it's no difficulty sourcing testosterone now.
Oh God, when you said they go to the gym, I was actually going to...
Well, they should go to the gym to exercise, of course.
I was actually going, why did he say that? Or did he mean GP? So sorry, they go to the gym to get testosterone because they can just get it there freely.
Which is freely available everywhere.
Yeah, on the internet and that, they can get it as well.
Yeah, sure. And they'll often tell you, guys will tell you they're taking pharma grade testosterone, that they've sourced themselves. Like it might say pharma grade on the pack, but sure, yourself, it probably isn't. But those kind of guys that are looking just for testosterone, they won't come to me. So the guys that come to me are interested in their health. They're interested to see whether testosterone could be the answer. And they're also equally happy if it's not. Okay. So they're not seeking a quick fix. They can get, if it's those risky or non-risk averse guys, they will go and seek it out themselves. Initially, when I started out, I did see those kind of fellas, guys who were seeking it, let's call it recreational use. But I don't see those guys anymore.
Okay.
They have other means of getting it. So your question was, do you just give them the testosterone? No, we don't. We spend about an hour with every guy that comes through the door the first time, because it takes that long to figure out what is going on here, because they have symptoms that could be anything.
Yeah.
And you've got to tease it out, work through it, rule out other things like obstructive sleep apnea or hemochromatosis, or all those kind of things can affect men and give similar symptoms. And then also do their bloods, wide range of bloods, including testosterone and other things, and work out their total testosterone, free testosterone. And if we can't find any other cause and their testosterone is low or their free testosterone is low and they have symptoms, we'll offer them a trial of treatment if their symptoms are bothersome. If their symptoms aren't bothering them, they probably wouldn't be in the clinic in the first place. But if it isn't bothering them, they shouldn't be on treatment either.
Do men naturally lose testosterone though as they get older?
They do, but they only lose about 1% per year. So that sounds like a lot, right? But it isn't really. It's nearly another thing that's going on. It's they're getting other comorbid conditions like obesity, hypertension, blood pressure. And we know with those kind of conditions and with aging, a different thing goes up, a thing called sex hormone binding globulin. And you've testosterone rolling around in the blood, but if it's bound to sex hormone binding globulin, it can't get off the train of sex hormone binding globulin, and it's not free to do its work. So we have to calculate what's free. What's the free testosterone that's left over that's not bound to proteins like albumin and sex hormone binding globulin, because that's what the body's interested in. That's what it uses. And if their free testosterone is low, well, that's really important. You need to...
sex hormone binding globulin.
Yeah.
Does that increase with age then?
It does.
And is it from 40s plus we're talking?
So, yeah. But remember what I said, it was the comorbid conditions.
Okay.
So as you get older, you get potentially, depending on genetics and lifestyle, maybe more unhealthy. And it's those things that drive sex hormone binding globulin that trap the testosterone and stop it doing its work. Now, at the same time, back to your thoughts, that you lose 1% per year. So you have two things going on. But if you ask me which is the biggest driver, it's the fact that your sex hormone binding globulin is going up.
So when someone comes into your clinic and they have some symptoms and you run the bloods, and you find that their free testosterone is actually low, they'll get potentially put on the treatment if they want to. But just say the free testosterone comes back as that it's okay, but they're still, their symptoms, they have that low drive, they don't feel it themselves, they don't feel like they did when they were 20, they're not able, the low libido can be a huge thing for men. Or just isn't that the joy in life? Isn't that it? Didn't you say earlier on that the colour is gone from the television?
Yeah. So guys say interesting things to you when you let them talk. So they'll say, I feel like I've been plugged out, like, a washing machine plugged out or Hoover plugged out or whatever plugged out. They've no energy, right? Or they'll say they're driving along and it feels like they're driving in the rain, but they don't have the window wipers on. Or they're watching TV and they're watching it in grey, there's no colour. So they're all kind of subjective things. It's not very clear, right? But these are what guys feel like, okay?
It sounds like depression, though.
Exactly. So exactly. So I'm telling you, guys that have low testosterone are often put on SSRIs. And for some guys, SSRIs are really important.
Just let you know, SSRIs are antidepressants.
Yeah. So antidepressants are really helpful for some people. All I'm saying is, for guys that aren't responding to antidepressants when they've got low mood type symptoms, you should think about testosterone as well. And if it's low, trial of testosterone is often a good thing to try.
So then I wonder though, before the SSRIs get prescribed, should the testosterone be prescribed? Would it not make more sense?
Well, it would, rather than that, let's say, we should at least be checking a testosterone level. Okay. So I'm not saying that testosterone is a treatment for manic depression or a guy who's, really, really got clinical depression. I'm saying about low mood, sadness, just not himself. And guys will know that themselves. They're a little bit narky, a little bit jumpy. They're just not right. And they know themselves, maybe, I don't think an SSRI or an antidepressant is actually what I need. They don't have the words to tell you exactly what they need. But at that stage, rather than saying, oh, let's prescribe you testosterone, no, let's just check your testosterone. Let's check other bloods, like the things we talked about, albumin and sex hormone binding globulin, and let's work out your free testosterone. And if either of those are low, then we may think about giving you some treatment if that's what you want.
Okay.
That's the way I think about it.
I think historically we would have teased men. They would have been the subject of...
Who would have teased them now?
Well, we know the midlife crisis, the typical midlife crisis in a man would have been, oh, look at him, he's like gone and bought a fancy car, or, a lot of men go around on their fancy bikes with their Lycra. People will say, oh, he's having a midlife crisis, he's moody and he's off doing this. But there is that turning point maybe in a man's life when he's looking back and over the life he's had and gone, Jesus, maybe I could have done more with myself, or maybe and that sadness comes in, the colour goes out of the television, like what you were saying. So it's a very real, tangible thing. And I think that we haven't yet put a name on it really without saying it in jest. But I love the fact that we're having this conversation, because I think that if someone's married to a man like this, or has a partner or a brother, and they see this kind of change in them, at least they'll be able to maybe suggest that, listen, there could be something endogenous going on here. It might be worthwhile going and getting seen to, rather than living your life kind of subpar.
And there's loads of guys out there who are walking around with a low testosterone and not feeling great, so it's the second most common endocrine disease in men. Okay, so number one is diabetes, but number two is testosterone deficiency. But there's a big hoodoo about testosterone. Like, when you think about testosterone now, Laura, what comes to your mind?
Joe Rogan.
Joe Rogan,
and his plethora of doctors that are taking his bloods every week, and he's injecting himself with whatever he needs to be. But he has a huge amount of money, medics behind him, so he can tailor it to his needs, I suppose. Because obviously testosterone's injectable, and you do need to monitor your patients. I gather,
absolutely. But your point about Joe Rogan's interesting. Like, we don't really advertise the clinic because we don't need to. Joe does all that for us. But what I would say is there's a huge stigma against testosterone. So the first time I heard testosterone, when we were inheriting a clinic from a guy called Andrew Wren, who's a great fella, was, is that not illegal? Is that not illegal? Because I wasn't taught it. And
I asked you on the phone when we had the pre-show. I said, is it legal? Is it legal? I said, well, he probably wouldn't be coming on the pod if it wasn't. But I know that there are back alley clinics as well.
Yeah, there are. Sure, there's back alley stuff for everything. I work in Rialta, for God's sake. But that's not what I'm saying. Is it feeds into what we're just talking about. There's a huge stigma around testosterone. Testosterone is just a hormone. Men have it, women have it. And you know what? If you don't have enough of it, sometimes you get some symptoms. And if you can replace it, you feel better. Is it a panacea for everything? Absolutely not. But I wouldn't sit in my clinic, and Emmett wouldn't sit with me in that clinic, if we didn't believe that it can help guys. I work as a GP. It's very, very rare that a patient will come in and thank you profusely for listening to them and for prescribing something. And the odd time it'll happen in GP. I have lovely patients, but it happens in the men's health clinic all the time.
And who's sending the men to you? The women?
Sometimes, they'll come with them. It's actually really helpful if loads of guys that come to me have male partners. Loads of guys have female partners too, obviously. But it's really, really helpful when the partner comes with them, because they'll come in and they don't know what kind of a clinic this is. They think maybe it's a back alley clinic or whatever, right? And I'll get them, the partner to sit up in the couch, and I'll say, let's say the patient's John. I'll say, John, say nothing now. And we'll say the patient's partner is Fiona. And I'll say, Fiona, now tell me about John, right? What do you want back that John has lost? And that's what they'll say. I want the old John back.
Okay.
Now, Jeannie, I can't say I can
that's
bring.
Very sad.
Isn't it very sad?
Yeah,
right?
It is.
So, and it is sad, right? And I am not saying testosterone is a panacea for everything, but if you've tried other things and it hasn't worked out, maybe go get your testosterone checked. But here's the big thing, right? You better know your numbers yourself, because remember, I went through GP, hospital training, medical school, and I would have said, right, whatever number comes back, if it doesn't come up in red, as in abnormal from the lab, it must be normal. But the guidelines are very clear. If your testosterone is under 10 and you've symptoms, reasonable to think about a trial of treatment. If your testosterone is under 12, but your free testosterone is under 0.225, same rules apply. You should, if you've got symptoms that are bothersome, you should be given a trial of treatment. Once they don't have contraindications, of course.
And if that free testosterone is okay, and the other testosterone, the non-free one, is okay, and it's coming in under those guidelines, but the man is still has symptoms, would you still prescribe it?
So it depends, right?
Okay.
So you know, and I know, you enter, the health professional game to do what?
Help people.
Well, it isn't to make money anyway, because there's easier ways to do that.
Yeah.
It isn't to work hours and hours and be away from your kids. It isn't to be working nights. It's to be helping people, right? Now, I have these conversations all the times with, I do a lot of GP training, and I have a reg that works in the practice and all of that. And I'd say guidelines are really helpful. And the reg would be really interested in guidelines because, exams are based on guidelines, Martin. And I'm like, geez, they are, but they're useless sometimes. They're useless sometimes for patients that are in front of you. Guidelines are the railway tracks. They should be keeping us on track. But you can leave the track, and it's okay to leave the track, but the patient better know you're leaving the track, and you better know you're leaving the track. And then you can make a shared care decision. So this is the thing, right? You can't walk around with a testosterone of 10.1 and have no symptoms, and a testosterone of 9.9 and have symptoms. That's crazy, right? Body doesn't work like that. So they actually picked a number because it was a consensus. It's a consensus that most guys will have symptoms with a testosterone under 15, but will treat a little bit lower, when they're a little bit lower. But guys aren't walking around, as I say, with a testosterone of 10.1 and having no symptoms, and then 1 year later have a testosterone of 9.9 and have loads of symptoms. It doesn't work like that. So your question was, do I treat guys? I treat them as they come in, and it all depends on the patient. Do we ever leave guidelines? Only if the patient is aware and I'm aware, and we make a shared care decision. Perhaps we do. Okay. I want to help patients. That's why I'm in the game.
And what does testosterone therapy look like? Is it people injecting every day? Is it once a week? How often do they have to come and see you? Let people know, because they don't know.
Yeah, and sure, I told you I started and I didn't know, so I remember walking into the clinic the first day and I was probably shaking because I was like, how am I going to look after these 60 guys that we've inherited now? But they were looking after themselves. They were well taught by the guy we inherited the clinic, Andrew Wren, and they helped me. Okay. So, because remember, it's very hard to get the knowledge. After that, we did a fellowship with a guy called Abe Morgenthaler in the States, who is the Rory McIlroy of men's health. Okay. So a great guy, right? And he would say the same thing. I'm in medicine to help guys, to help them. Okay. But your question was, do you inject or what do you do? Okay. It depends. There's a whole suite of treatments, including no treatment. So if they've got symptoms, but it's not bothering them too much, or they go through the pros and cons of testosterone treatment and it isn't for them, there's no problem. They can come back later if they want to, if it's bothering them. But if they're bothered and they want to try some treatment, you have gels, you have injections, and within injections, you have short-acting injections, long-acting injections, intermediate injections. In the States, they've got a nasal spray.
Oh, yeah.
We don't really seem to have that, even though actually it's probably quite good. They have oral testosterone in the States as well.
Do they? Is it?
Yes. What do you think when you hear oral?
Well, I just think like the bioavailability of something.
Yeah, you have to take
oral.
high doses. Yeah. We used to think orals and originally testosterone was toxic to the liver, but there's a different formulation now which is absorbed through the lymphatics actually.
Okay.
Really interesting. But you've got to take high dose. Yeah. I don't prescribe oral because it's just not something that I was ever trained in. I prescribe either gels or injections, but within that there's loads of different choices. And your question was, are they monitored? Oh yeah, absolutely. So we will give them a prescription to get them to their next appointment. I do not. So we are a men's health clinic, not just a testosterone clinic. We'll come back to talk about other things that we do, but it is not okay. And I am a GP, so I understand. It's not okay for me to run a clinic and say, now there's a script and go to your GP and get these bloods done. That's not fair on the patient, and it's not fair on the GP either. GPs are busy. They don't have time. And often it's outside of their kind of scope of practice that they might have an interest in something else, joint injections or whatever, So it's not fair to just point them back to their GP. So we look after everything. So if they have a high cholesterol, I'm on it. If they've got high blood pressure, I'm on it. If they're over the age of kind of 47, 48, 50, I'm sending them for a screening colonoscopy. If they're over that age and their lipids are off, or they have family history, or they have erectile dysfunction, I'm thinking about a CT angio to check their heart. And maybe we should talk about erections. What do you think?
I'd love to talk about erections.
Right, okay.
My second favourite topic.
Right, second. What's first favourite topic?
Vulvas.
Right, well, I'm no expert in that. One of us is. Yeah. So guys would come to the clinic then and they'll think testosterone is the answer for their erections, right? And it can be helpful, but isn't the best medication for erections. What do you think is the best medication for erections? What do you think?
Viagra. Or Cialis, or
one of those, right? Okay, you're right, yeah. 10 out of 10, right answer, right? Okay, because testosterone is helpful. If your testosterone is very low, actually, testosterone would be really, really helpful for erections. If it's not that low, it can still be helpful, but it isn't more helpful than the vasodilators like Viagra, as you call it, which is sildenafil, Cialis, which is tadalafil. There are others. They're amazing medications. I mean, I think everybody knows the story of how Viagra came about.
Why don't you indulge the audience, Martin? I'm sure they'd love to hear.
It just goes to show when things don't work out, one should never just throw things out. Yeah. Right? So Pfizer, as you know, did a study a long, long time ago about systemic blood pressure. So blood pressure, high pressure in your vessels. And they thought if we give something that'll dilate the vessels, that'll decrease the pressure. Well, that makes sense, doesn't it? So they gave them huge dose, 800 milligrams of sildenafil. It wasn't called Viagra then. And lo and behold, they did their trial, invested millions, and what happened? It worked, but not fantastic. And tail between their legs, disappointed, I'm sure, and lost a lot of money. But they noticed, or at least somebody noticed, that the packs from the placebo arm were being sent back, but the packs from the active treatment arm with sildenafil or Viagra in it weren't being sent back. And somebody thought, that's a bit unusual, isn't it? We give one or two of them a call and see why. And the reason was they were having fantastic...
raging boners.
Right, they were having fantastic erections. Yes. Okay. And that was great for them at 800 milligrams.
Oh my goodness, I'm surprised it would ever come down after that.
That's the thing called priapism. But these kind of medications don't really cause that. So we know they're safe in really high doses, and then they dial back the dose a bit. And that's how Viagra was born. And
do you know that it's also good for period pain, but they just never pursued that avenue?
That's really interesting. Yeah. And I worked in pharma, as you know, so I can get that. I understand that. And often simple solutions and cheap solutions are often overlooked. Yeah. So I prescribe Viagra in the clinic, absolutely. But what do you think is one of the problems when a guy takes Viagra? What do you think is one of the problems? What do they tell me?
They get an erection, but it only lasts for the time that they take the tablet for, and then they need to take another one for the next time they have sex.
Right. So this is what they tell me.
And then they get a headache afterwards, some of them.
Yeah, for sure. Right. And you're dead right. But they tell me other things too. So they tell me that I feel like I'm on the clock, Martin. And I say, what do you mean by that? Oh, I'm popping a pill and now I'm on the clock. It better happen because, I've got to take it 2 hours beforehand. So I've got a plan. I've got to know when they're going to have sexual intercourse. And then I feel like, well, gee, I've got to use it. And that's not great in a relationship.
Mm.
What you want is spontaneity and, don't want to be on the clock,
Yeah.
right? And you're right, some guys get side effects from Viagra. They'll get facial flushing and things like that. That's because what you're working on is a thing called PDE5s, okay, in the penis, and you're inhibiting them. The PDE5 is like a little Pac-Man, gobbling up all the good stuff in the penis, which stops vasodilation. And what we do is we inhibit that, and that allows vasodilation of the penis. But there are other PDE5s in your body, PDE5 or PDE11 in your back. There are other ones in your brain, around your face, and that's why they get facial flushing or a little bit of nasal congestion, a little bit of reflux or back pain. They get pain in the back, right? They don't be telling you that. They'd be telling me this.
It's just not
okay?
from the enthusiasm.
Yeah, maybe, yeah.
Do they ever say to you as well that it feels a bit mechanical?
Sure.
Yeah.
So some guys, and this is what we should be really focusing on, some guys feel like it's nearly, I'm falling apart here. This is a medication for maybe a 70 or 80-year-old, and I'm only 45 or 50. And am I really taking this? They kind of feel like it's a thing against their masculinity, right? So back to the Viagra, right? I do prescribe Viagra. Viagra is a great medication, but it doesn't allow spontaneity. So the number one medication I prescribe in my clinic, or that Emmett prescribes with me in Optiman, is not testosterone. It is a thing called microdosing of daily Cialis, a thing called tadalafil. Game changer. Now, how many guys come into your pharmacy with a script with a thing called daily Cialis?
Very few. The only men that come in for that are men that are trying to conceive with their partner, and they find the whole idea of having, the way you're ovulating and you have to go.
Yeah, performing monkey.
So, that performance, anxiety, they'll find it hard to actually perform when they have to perform, when they know there's going to be a baby, potentially a baby at the end of it. So that would have been the really only time.
If that kind of a guy came in to me, would I use the words erectile dysfunction for them? I mightn't, okay, because that's the thing called psychogenic ED. Okay, so you might say, well, it's in his head, Martin. Well, I think all parts of erection difficulties somewhat is in your head, okay? But that guy going on microdosing daily Cialis can be helpful for a thing called psychogenic ED, which is not organic ED. So psychogenic ED is, as you said, the guy who now is thinking about the chore of having to have sexual intercourse with their partner so that they could get pregnant.
Yeah, there's nothing sexy about.
It doesn't sound much fun, does it?
No, not at all.
Which of course any man that comes in and talks about their fertility, which is common conversations we have, they often find IVF so stressful. But it's so stressful for the female partner that males feel like, gee, they can't really be talking about it. It's the females the one taking all the medications, having to have procedures, egg retrieval. But guys find that the whole process, it's both stressful on the couple, but stressful on the men too. So daily Cialis, let's talk about daily Cialis.
Yes,
now.
Let's go.
It's an interesting medication, right? I would think about Viagra as the sticky tape. It's like the Band-Aid. Helpful, but the disease is progressing. So I'm talking about not guys with psychogenic in your head ED. I'm talking about guys who've developed erectile dysfunction because of all of the risk factors that cause problems with your heart. Okay, so we'll talk through that. And daily Cialis is a really good medication for men. Okay, because it decreases their blood pressure a bit. Okay, it helps the lining of your vessels, a thing called endothelium. It decreases inflammation. And we know inflammation is one of the drivers for cardiovascular disease. What if I was to tell you that a guy, Ian Thompson, a guy way smarter than me, did a trial in the States, which he looked prospectively, i.e. from now into the future, about guys who presented with erectile dysfunction, and that 15% of them within 7 years would end up with a heart attack or a stroke. So I think we've got to start looking at erectile dysfunction a little bit differently. There is psychogenic in your head ED, grand. They need help for sure, but that's just transient. There's a stressor in their life. They're putting on their sympathetic nervous system, fight and flight. They're not using their parasympathetic nervous system, which is rest and relaxation. And with the right help, and often with sex therapy, they can cure themselves, and it is not a long-term thing that they need medication. Although with these guys, sometimes I use daily Cialis as well. It's a kind of chemical CBT approach, and it's really helpful. No, what I'm talking about is disease-causing erectile dysfunction. So if you look at the column of risk factors for heart attacks, one of them would be smoking, wouldn't it? Okay, one of them would be high blood pressure, diabetes, obesity. Well, if you look at the risk factors for erectile dysfunction, each one of them are in it, aren't they? And I think I talked to you before about the size of pipes. Did I? I think I did, yeah. So it may be the easier way to think that there's two theories. There's the endothelium theory, and we can talk about that, about inflammation, but it's a bit harder to get your head around, right? But if you think the size of your penile artery, the one that brings blood to your penis, is 2 millimeters, okay? You'll start showing problems in a small pipe that's 2 millimeters in size before you'll start showing problems in another pipe that's double the size, 4 millimeters. And do you know where there's a 4 millimeter pipe? Your coronaries, okay? So when I see a guy with erectile dysfunction, they're thinking, I want the pill, doc, or I want a solution. And I'm thinking, grand, you'll get that, but I want to check your heart out, kid. All right.
Okay.
So I think...
Does it inevitably come back that there is issues with the heart then when you send them for their...
It depends on how long they've had symptoms.
Okay.
How many of those risk factors they've had, and the degree of erectile dysfunction, of course, over time. And yeah, there's a big correlation. I told you. Over 7 years, 15% of those guys, from the first day they have erectile dysfunction, they will get a heart attack or a stroke. Shocking, right? Heart attacks now, you might survive, right? Strokes, you might survive now, but they are life-changing. You know, life-changing. So I think it's not sexy to start talking about lifestyle, diet, exercise. Everybody thinks it, you know, but these are the things that define us. So there is a problem with declining sperm, declining testosterone, and erectile dysfunction in men. And they are often associated, you'd say, with aging. I don't know. I think it's more likely to do with all these comorbid conditions. So on the other side, when sperm and testosterone are declining, on the other side, obesity is rising. And I think there's a huge correlation with that. So men, I mean, often they'll get erectile dysfunction, okay? And I think I told you this before, that only 44% patients or men will inform their partner that they have problems with erections, okay? And only 50% will go see a doctor. So they're suffering, aren't they? But they're not telling anyone. Yeah. Shocking, isn't it?
Yeah. And now, I don't want to in any way seem like a generalist, because it's not my area of speciality, but men, like, don't they link their energy, their happiness, their virility to their erections in a lot of cases? And if it's not working, you know, that can in and of itself then make the mood low, make them feel
so 33%,
less of a man.
33% of guys who have erectile dysfunction have depression. Okay. 33% of guys who have erectile dysfunction have anxiety. Okay. So they're comorbid conditions, right? Now, which caused which? But it goes with it. So erectile dysfunction has big impact on the man, but it's a big impact on the partner too. And the partner, if 44% of them are being told, well, there's a huge proportion that aren't being told, they might think there's something else going on, mightn't they? You know, so men are poor to talk. They're getting better. I think younger guys are better at talking about things. And they're poor to present to doctors. And when they present to a doctor, I told you this before, that it all depends on their first interaction. If their first interaction is positive, that's good. They'll come back. Okay. But if it's not, it may not be.
As in, if the doctor that they present to knows what they're talking about, or just shuts the book, is that it?
If they entertain the symptoms that men have, and they actually have a bit of compassion and they want to help, and I think most GPs do, then it'll be a really positive experience. And most GPs treat erectile dysfunction just grand. They're treating it really well with weekend Cialis or PRN, or as you require Viagra, and that's grand. You know, that's great. They're doing a great service. And most pharmacies are doing a great service to men. Even online, it's great, because guys there'll be barriers to guys going to even a pharmacist to get Viagra Connect, which is over the counter now, or to come into me. So maybe online. There's nothing wrong with online stuff. You have to make it easy for men to get the tools they need. All I'm saying is erectile dysfunction is an important sign. It's an important sign, and we need to start thinking about the heart.
I want to talk about two things about this Cialis and the... So you mentioned microdosing Cialis.
Yeah.
Explain what that means then to the people.
For sure, right. So Cialis comes in a 5, a 10 and a 20 milligrams, right? You'd think in Ireland, surely, the 20 milligrams would be the most expensive and the 5 would be the cheapest. I've never prescribed 5 milligrams because it's really, really expensive. Okay. So I prescribe 10 milligrams. I say take half it and take it every day. Okay. So that means a small dose every day. After 2 weeks, they're going to have a concentration in their bloodstream that would allow spontaneity. So it'll allow for them to have erections when they need it. So now they don't need to plan sexual intercourse. They get confidence back. This is fantastic. Okay, but what if the medication they're taking is actually helping their heart? That's amazing.
And their brain, dementia and things like that,
so
isn't that?
We now know that there's emerging evidence that people who take PD5 inhibitors like Viagra and Cialis have a lower risk of dementia. Now that's really interesting, isn't it? Okay. We know it. I think it's hard to get your head around what endothelium is, but it's the lining of all your vessels. So you've blood supply all over your body, back of your eye, to your brain, to your heart, to your kidneys. And over time, high blood pressure, smoking, they will damage the lining of your heart, or damage the lining, of your vessels that can lead to your heart, but vessels anywhere, okay? And it's that causes problems, okay? And Cialis seems to change the lining. Really interesting. It decreases a thing called IL-6, which is an inflammatory marker. It decreases high-res CRP in the endothelium. Okay, it increases nitric oxide. And this, it seems, can help with your lining all over your body and decrease your risk of things that can cause dementia, things that can cause heart attacks, okay, heart failure, things like that. It's really interesting.
Is this preliminary research that we're seeing coming out now isn't yet something that's...
No. But it's the evidence looks really, really promising. Okay. And here's the thing, right? We now are seeing things where daily Cialis can start improving the tissue in your penis. So think about it, right? Why do you get an erection? Right. You might get an erection to have sexual intercourse, but men get loads of nocturnal erections. Why are they getting those? They're asleep.
Because it's keeping the penis healthy, I would presume. The body's way of doing that.
They need to get good arterial supply in to their penile tissue. The only way is through an erection, okay? With a good arterial supply of oxygenated blood comes oxygen and nutrients, okay? But if you start getting damage to the lining of your vessels and you get this endothelial damage, you'll start to get less pressure, okay? And less pressure means problems with supply of blood to your penis, which would mean erectile dysfunction. So you'll get less erections at night, okay? So Cialis increases the number of erections. It increases the amount of arterial blood in, and we know all of that helps with the soft muscle that's in your penile tissue. And you can see, rather than atrophy or weakening of the muscle, you start to see changes and hypertrophy or strengthening of the muscle with microdose and daily Cialis.
Isn't that mental?
Mental. And you know what? It's cheap stuff.
It really is. Yeah.
So it's cheap. So, okay. So here's another problem I have, right? Who decided it was okay? So let's say I have 2 patients, right? And I have one guy who's under what we call the GMS card, right?
I know what you're going to say already.
Okay, what am I going to say?
You're going to ask why are people only allowed 4 Viagra pills a month?
Why is that?
So the HSE decide that. Someone in the PCRS, so that's the primary care reimbursement services. So some person in there decided that will allow people to get 4 Viagras or Cialises or whatever it is a month. So they're allowed to have, maybe it's just maybe it's the Catholic Church.
Yeah, who knows?
They can have one sexual intercourse a week or one whatever they need to.
That might be great for some guys. That might be too much for some guys.
Yeah.
And it might be certainly too much for a couple, let's say, or whatever. But for some guys, it's not enough.
No.
Right? And what if we knew that some of the medication we give can actually help this guy long term and decrease the risk of developing worsening erectile dysfunction or developing heart problems? Well, should we be limiting that to 4 times a month?
You see, that's called forward thinking, and there isn't an awful lot of...
No, there isn't, right?
The thing about common sense is that it's not very common, isn't that right?
yeah, that's it. It's not. Everybody should know about microdosing daily Cialis. Now, that's not to say everybody can tolerate it, okay? Or that it's the right medication for everybody. Of course, there's people that are on oral nitrates and all of this kind of GTN sprays. Yeah, but like I'm just using...
for the general public.
Exactly.
You put it in the water next, Martin. Everyone will be going round with with spontaneous
maybe we'd have
erections.
But maybe we'd have less cardiovascular disease.
Well, this is it.
Okay. And it never takes the place of stopping smoking, getting your blood pressure well controlled, diet and exercise. Okay.
And on that,
sure.
When people come to you and they're smoking, what do you say to them?
I won't treat them.
Okay.
Yeah. I'll tell you, that'll concentrate the mind. Now, most guys that come to me don't smoke. Some vape. And I don't know what your thoughts on vaping are, but mine would be, I'd be quite anti-vaping. I just
think that we don't yet have enough evidence to say that it's
safe. Would you let your kids vape?
Absolutely not.
Yeah, but kids won't listen to us anyway.
No, they won't.
But I would say I wouldn't vape myself. Anything you're heating at high temperatures and inhaling, it's not great. Okay.
Can't be good for our lungs. I'd say there's going to be lots coming out in the future about how bad it'll be.
I'm sure. I wouldn't treat a guy who's actively smoking, but I'll tell them that. And I'll tell them it's going to take a few weeks to get things sorted. If you want some help now to stop smoking, I'm happy to do that. And most guys will stop then.
Okay.
And if they don't, I ain't treating them.
Okay. And why is that?
I would say, I told you before, I'm in the space I'm in because I want to help guys, right? Mm-hmm. But I am only meeting them. So the people who are responsible for the patients who attend me for their health, is that me? Is it? It's not. It's themselves. So I'm stressing that. If you think your GP is responsible for your health, you're wrong. If you think you're attending me in the men's health clinic and I'm responsible for your health, you're wrong. You're responsible for it. And if you're smoking, right, you're not being responsible. Why would I be entertaining that? So no, don't treat if they're smoking. They'll stop though. They'll stop. Or they'll tell me they'll stop, I suppose, right?
This is it.
Yeah. You can't be sure, I guess, right? But they'll take it serious. If they understand that look, I'm quite happy to work with you now for the next few months to get you right, then they'll engage.
Okay.
Yeah. And of course, I do tell them they'll save loads of money. I'll tell you a funny one. So I had a guy recently who I said, how much you smoking? And he said, whatever he said. And I said, did you ever tot that up now? How much this costing you a day, cost a week? It was quite a substantial amount of money. I said, Janie, if you tot all that up over a few years, you could buy a yacht. Do you know what he said to me?
What?
Where's your yacht?
Did he? Cheeky bugger. Always an answer.
I don't have a yacht. I don't smoke, but your money goes elsewhere, doesn't it?
My goodness, it does indeed.
Yeah.
Can we talk about sleep apnea and men or sleeping in general?
Yeah, so sleep's really important. So we talk about, in the clinic, the 4 legs of a stool, okay, that we're sitting on. Diet, we should talk a little bit about diet. Exercise, okay. Sleep. We'll come back to it. And stress reduction. So all really, really important. And we will give guys that come to us advice around that. Okay. Sleep. I had a guy in this week, walked in, and within 2 minutes, I could tell you what's wrong with him. It's not that I'm any good, but I've seen the movie before. Big guy who is, if I had his partner, she didn't come with him during the week, but he presented as tall guy, increased abdominal waist pattern, increased neck girth. So he's a big fella. He walks in and he tells me he's wrecked. I said, Janie, are you? Right. Tell me more about that. How's that affecting you? I'm tired all the time, Martin. Are you? Right. And how's your sleep? It's all right. Do you snore? I do. If I was here and you were in the next room, would I hear you snoring? I would. Do you feel tired in the afternoons? I do. Do you have a bit of a dry throat in the morning when you wake up? I do. Right. So that guy has obstructive sleep apnea. If you ask me the number one diagnosis I'm making guys who are tired all the time, it's obstructive sleep apnea. They're snoring loudly. Okay. They're having little episodes of not breathing during their sleep. So if there's a lady who's listened to this podcast or a male and their male partner is snoring like a bear, will you ask them to get checked for obstructive sleep apnea?
But does that involve going for a big sleep, clinic and all the rest?
So for an official diagnosis, yes, it does. But you can make a clinical stab at it by just asking them that. Okay, obviously to get a CPAP machine and all of that, you need a diagnosis. Well, generally you do of sleep apnea. Now, the thing about sleep apnea is every minute you have it, you're taking minutes off your life. Okay.
And why is that? Will you explain it?
If you go to bed, so I have a 4-year-old. Okay, her name's Chloe. She's very smart. She's the only one that I know who's 4 that understands sleep. So, Chloe, do you sleep all night? I don't, Dad. Good girl, Chloe. And what happens? I wake up during the night, Dad. Yes, you do, Chloe. And what do you do, Chloe, when you wake up during the night? I go back to sleep, Dad. Exactly. So Chloe's telling me that she goes to sleep alert, and then she goes into a deep cycle of sleep, right? Into REM sleep. But that doesn't last. She comes up again to alert. She wakes up during the night. But she knows that's just the end of one sleep cycle, Dad, and I'm going into the next sleep cycle. Now, you need deep REM sleep to get relaxation of your mind and your body. In deep REM sleep, okay, we only cycle through it during the night. You get rapid eye movement. That's the REM bit, the name of the band, okay? But you get decreased adrenaline, decreased cortisol, decreased noradrenaline. If you're a man, you're getting nocturnal erections. You're getting short-term into long-term memory, okay?
It's all happening in the REM sleep. All
exactly.
of it.
But let's say you don't get down to REM sleep.
Yeah.
Let's say you take sedatives or alcohol. Well, you're going to be sedated, but you're not getting down to deep sleep.
And why don't you get into deep sleep if you're sedated or
because it's
alcohol?
an anesthetic. It's just keeping you at one state of sedation. You're not getting into deep sleep. And you know what? Those guys and girls that take alcohol to sleep or take sleepers to sleep, they're at increased risk of dementia. Of course they are, because they're not getting short-term into long-term memory, okay, in REM sleep. But back to our guys with obstructive sleep apnea. What they're doing all the time is just hovering around alert, and they're all the time going into just shallow sleep up again when they're gasping for air, and they'll be waking themselves out of sleep the odd time, but mostly they're doing just this apnea spells, which they won't know of, but their partner will. There'll be gaps in their sleeping and they're snoring really, really heavily. And if you put a blood pressure cuff on them, their blood pressure is through the roof. So most guys who come to me who have obstructive sleep apnea, they're probably leaving with a blood pressure medication as well, because they never knew they had high blood pressure.
And can we just say that blood pressure in general, you can be going around with it and it can be as high as a kite and you don't actually know, you're showing no symptoms of it.
There's no symptoms until there's a big symptom.
There's a huge, yeah.
And the big symptom could be a bleed in the brain. It could be a stroke. A stroke can be either a bleed, which is less likely, but a clot, which comes after wear and tear, a heart attack, okay? All the same things, or erectile dysfunction.
Mm-hmm. So would you advise then anyone, like men or women out there, to go and get your blood pressure checked? So you know that you have blood pressure.
So this is my advice, right? If you come to me as a GP and you think I'm responsible for your blood pressure, I am not. Okay, you might say, well, no, Martin, you are. I am, but really that's the wrong way of looking at it. Every household should have a blood pressure machine. They're not that expensive, okay? Or at least in a parish you should have one, and maybe you could share it around, whatever way. But you need to know your own blood pressure readings, okay? And if they're high, you need to do something about it, because it's going to cause a problem. Too much pressure in pipes is never good. All right? Okay. So obstructive sleep apnea, just to get back to that, right? Guys will feel tired, okay? Guys will be wrecked. They'll be snoring really loudly, and they need to go to their GP and say, geez, I think I might have sleep apnea. They might. And they need to get their blood pressure checked as well.
And if they don't want to bother going to the sleep clinic, or they have to stay overnight and do the sleep clinic, or else do they have to put...
Okay.
Can they do something at home?
Huge big changes.
Okay.
Huge changes in the sleep world.
Okay.
Okay. And there's loads of options now. Okay. So let's say you couldn't afford to do anything, but you only snore when you lie on your back. There's simple interventions you can do. There is, rather than talking about brands now, but there's simple €40 magnetic balls that you can buy that make it quite sore if one half goes on one side of your t-shirt you wear to bed, the other side, one goes on the other half, and it's on your back. And if you roll onto your back, it'll hurt a little bit, so you'll roll off it. Okay, so that's a simple solution. There are pillow straps that you can put around your abdomen, not under your head, and they stop you rolling onto your back. That's really helpful. Okay. But you said you have to go into a sleep clinic, and then you might need health insurance, or you might need to wait 5 years on a public list to get it done. There is loads of stuff now which is using tech, a thing called watch pat devices, which are pretty good at detecting what we call apnea spells, or no breathing. Apnea is lack of breathing. And when you have lack of breathing, do you know what happens to your oxygen? It goes down. So if you were in an oxygen probe strapped up to a bit of tech called a watch pat device, you can diagnose obstructive sleep apnea without going near a sleep clinic. Now, a sleep clinic is really important. Okay, it's really, really important for those that are borderline or that have, different patterns of sleep, and they're really good at giving formal sleep studies, and you need that too. But if you're asking, is there other options? There are other options. And
is there any other treatment for sleep apnea other than the CPAP, though?
Okay, so would you like to wear CPAP?
No, I wouldn't.
Why wouldn't you?
God, these look awful, and I'd be uncomfortable. Yeah. I find it difficult enough now to.
But what if you slept amazing with it?
Yeah, but the noise and and all the rest. So, I'd do it if I had to.
So all CPAP is, it's high pressure, trying to keep your airway open when you're breathing. Okay, so yeah, I could see why guys wouldn't want CPAP, right? But
especially if they're on the microdose and the Cialis and they want to be spontaneous.
Sure, and throw it out the window. Yeah. The other things you can do is get a thing called a mandibular advancement device, and a lot of dentists will do that. The problem with those is sometimes it can cause a little bit of TMJ pain, right? But what if they didn't have sleep apnea when they were 3 stone lighter?
Okay.
What about losing some weight?
Okay.
Will we go talk about that?
Yeah.
Okay. So how good are men to come in and ask GPs about the new medications, the Ozempics, the Saxendas, the Mounjaras?
I wouldn't say they're great at all.
No, they're not fantastic, right?
Do you prescribe them?
It depends. Not as a first line. Has to be diet and exercise first. But I think the danger with these medications is we don't know their long-term safety. But that's the case in a lot of things, isn't it? Yeah. But how are we fixed with long-term safety of obesity? How good is that for us?
Yeah.
And back to inflammation. I said inflammation is probably the biggest driver of cardiovascular disease. What's the biggest killer of men?
Cardiovascular disease.
Bang on, right? What's the next biggest? Cancer. Okay. What if we thought inflammation was involved in both?
Oh, yeah. What?
And what if we now start to see studies that show that some of these medications cause anti-inflammatory changes? Okay? Because you know what obesity is? Obesity is a pro-inflammatory condition. Inflammation is bad.
You see, and I've had lots of obesity experts on here. I've had just Carell LaRue there. I've had Mick Crotty.
I'm not an expert in obesity.
And the whole obesity issue is that the diet and the exercise it's an overly simplified version for some people, particularly if they're in the obese category.
Sure.
They need that Ozempic, that Saxenda, and they need to be on it long term. Like it's a lifetime medication, because they'll get down and then they go off it, they go back up again. So it's nuanced, isn't it?
Again, back to medical school training, hospital training, GP training, right? If you just hold the knowledge you have, well, you're not much good to your patients. So I used to think that, well, all they have to do is eat less and move more. But you know what? That's insulting to patients. It's not fair. Because, only 10% of patients can lose weight by eating less and moving more. And maybe their best go at it is their first go. Okay. There's a thing called set point in weight, and Carell LaRue and Mick Crotty and Donal O'Shea, they're the experts in that. I'm not the expert. I'm just telling you what they tell me. That it's unfair and it's unkind to patients to talk about obesity as the answer is move more and eat less. That's not fair. Okay. Sometimes they need some help. And I'm a huge fan of the medications that are available. I'm just telling you, I will tell the patients I prescribe it to, you know what? I don't know the long-term safety of this. But you've maximized everything you can. And I know the long-term safety of obesity isn't good. So I'm happy to prescribe it if you wish, if that's what you want.
Yeah.
And let's see how it goes for you.
Getting back to the apnea bit, sometimes the apnea can be helped by losing
But
weight.
of course it can. Let's go back to the guy that walked in during the week, and he, within 2 minutes, anyone who sits in my chair would have made that diagnosis, not just me. I've just seen the movie before. But he didn't have heavy snoring. If I ask him and say, let's say his name is Paul. It wasn't Paul, but we'll call him Paul. So let's say, Paul, were you snoring 5 years ago as loudly? Gee, I wasn't. What weight were you then? He was a lot lighter.
Okay.
So you don't just put weight on your toe. You put weight on everywhere. And if the gap in your airway through your mouth is that little bit smaller with excess weight, that could be the tipping point.
And are you talking about the weight around the neck that kind of can compress it a
Yeah.
little bit?
Now, so it comes down to genetics too. So I won't make your day bad and ask you to look into my throat now. But if you looked into my mouth now, you would see my tonsils, okay, you'd see my uvula and you'd see the base of my tongue. But actually, if I look into a lot of guys who are overweight, you won't see their tonsils. I couldn't tell you whether they have tonsils or not. I couldn't tell you whether they've got a uvula or not. All you'll see is the base of their tongue nearly rammed up to the roof of their mouth. Now, in really thin guys, sometimes you can see that too. And that's down to angles of the jaw. A Malin-Patty score is what we call it. But it's simply just, can you see more than just the base of the tongue? And the more weight you have on, the more lack of space there is. And nose breathers at night, they don't run into much problems with sleep apnea. So that's why you hear of guys taping their mouth. And I don't know, have you ever heard of that?
Yeah, I've heard of the whole, that mouth taping is a huge trend on social media as well. But
I think a lot of it is to just try and get to that point where there's no obstruction. Okay. But mouth, I'm not telling go home now and tape your mouth. Imagine you've nasal obstruction or deviated septum or sinusitis. That would not be a good idea.
But what does the taping of the mouth do?
The idea is, I suppose, that you're a nose breather, or you try and get to a point where you're predominantly breathing through the nose at night, which I suppose if you have sleep apnea, that's helpful. But I'm not saying go and tape your mouth. I'm just saying some guys come to me and they're taping their mouth. Okay. Yeah.
Who's the oldest patient you've had in with you?
So I have a fantastic fella who drives down from Northern Ireland to see me. He is in some nick. Okay. Is he on testosterone?
Yeah.
He is. Yeah.
How old is he?
So he's nearly 90 now.
Wow.
Yeah.
Okay, because I wanted to go back to the testosterone questions, if you don't mind.
Yeah.
Because there was just some. So sorry, if someone is given testosterone,
sure,
exogenous testosterone, which means they're either injecting it or they're using the gels, will their testicles shrink and will they stop producing their own testosterone?
Fantastic, great question. Okay, so if you take testosterone, right, there'll be a lot of testosterone in your blood. Your blood goes to your pituitary. Okay, your pituitary picks up, geez, a lot of testosterone around. I ain't going to send any signals to make more. That's the signals they send is LH and FSH. Off they go. So your testes will atrophy, or they're not needed. You're getting testosterone elsewhere. So your testes will get a bit smaller, a bit softer. And you know what? The switches that are being sent from your brain to your testes to produce testosterone, the same switch on the other side is FSH, and that gets knocked off as well. Their sperm is gone.
Does this happen in men that you're treating, say, normally?
So remember, I was saying testosterone is not a panacea. It's not a panacea for every symptom they have, and then testosterone is not for everybody. Once you go on testosterone, you should be thinking, this is a treatment for life. And you know what else you shouldn't be planning? Having a kid.
Yeah.
Right? Really interesting. What if you take away testosterone? Does your sperm production come back? Let's say you wanted to have kids down the line. Let's say something happened or whatever, and you wanted to have kids. I'm telling you now, if I put you on testosterone, okay, your own production of testosterone will be knocked off, okay? Your own sperm production will be knocked off. If I take away testosterone, there's a good chance, a really good chance that everything will go back to normal, depending on how long you're on it and what dose you're on. But here's the thing. I always tell the guys, your sperm quality will not return to the same. Okay. It won't return to the same level.
And do we know why?
I don't know why. I don't know why, but I would advise any of my younger guys who go on testosterone to bank their sperm. Now, here's the other thing you have to tell them. If you're saying bank your sperm, okay, what are you going to do with bank sperm? You can't go down on a wet Tuesday and go get it. That is an IVF process.
Yeah.
And we just talked about IVF. IVF can be really stressful.
Yeah.
Okay. So, so you have to consent guys correctly. So back to our guys who are taking testosterone
in the gym,
recreationally, we say. Okay. Now, and we should talk about them again in a second, but let's say that they're taking testosterone, right? A lot of them don't even know that it could potentially affect their fertility.
Yeah.
And there's nobody monitoring their bloods. Okay. But should we think badly about those guys?
Well, no, we don't. Like, we shouldn't think
So
ill of them.
I have guys and ladies, I have guys and ladies who are addicted to certain substances that attend me as a GP. Okay. Now, what should I do for those people?
Absolutely help them the way you would any other patient.
Where is a guy who's addicted to anabolic steroids or to recreational testosterone going to go?
I know, nowhere.
Right. Okay, so we've got to change that.
Yeah.
We've got to change that. Now, I'd be happy to look after them, but you've got to have a dedicated, probably government-supported place where these guys can go. Because you know what? They need help too. And what if it was an addiction? Oh, why isn't it? Of course it's an addiction.
Yeah, and they'd need to be weaned off very slowly as well, wouldn't they?
Only if they wish. But what if they want to stay on it? Shouldn't it be okay for them to get their bloods done once they understand the risks they have? So if you take anabolic steroids, right? If you talk to any patient or any guy who's on anabolic steroids and you tell them as a doc, that's going to kill you. Do you know what they'll tell you? They'll tell you don't know what you're talking about. Because in a way, they know it isn't killing them right now. The problem is you need to say, it's going to cause you problems down the line. Okay. And this is the bit. And patients or guys or girls even who are taking anabolic steroids, they know it's not going to kill them today. Okay. And they just have a different way of looking at their body. And we need to be supportive to them and we need to be kind to them. Okay. And dismissing them, saying that it's going to kill them.
That's quite a blanket term, though. It's going to kill you. How is it going to kill them?
So they do run into trouble. They run into trouble. They run
Mental
into
health
trouble.
wise?
No, I'm talking about physical trouble.
Okay.
So they're more likely. Okay. I'm not saying absolute, but they are more likely to run into problems with liver problems, blood pressure problems, and a thing called hematocrit. So hematocrit is your blood count, right? If you take, so what is anabolic steroids? They're precursors to other steroids like testosterone. So they're the building blocks. So if you take that, you're going to get more testosterone around, you're going to get more other hormones around, right? Okay. The problem with taking testosterone, and we have to consent guys around this as well, is hematocrit, blood count. So if you take your testosterone, let's say I had a guy in my GP surgery recently who came in and asked me to check his testosterone. I said, oh, that's really interesting. Are you worried about it? And he said, no, I'd just like to know. And I checked his blood count and his hematocrit was raised. I checked his on switches for making his own testosterone. Lo and behold, they're knocked off. This is a really interesting case, isn't it? His testosterone is high. Yeah. Well, I just said, let's say his name was
Peter.
Peter, right? I said, Peter, you've got a really interesting set of bloods, Peter. Either you're on testosterone or we're going to be writing this case up. Are you on testosterone? I am. Okay. So they're on testosterone. Okay. So it's okay to be on testosterone once you're watching your bloods. Okay, so everybody thinks we're watching their prostate blood test. Yeah, sure we are, right? Okay, we'll come back and talk about prostate blood test in a minute. Okay, but we're watching their blood count because once you take either the precursors of testosterone or testosterone, your red cell lives a little bit longer. If your red cell lives a little bit longer, up goes your hematocrit. And if your hematocrit goes too high, that can be a problem. Okay, you get increased risk of clots. Clots in your legs, that's a DVT. Clots in your heart, that's a heart attack. Clots in your head is a stroke. Clots behind your eye is blindness. Okay, and we don't want that. Okay. Now, we monitor our guys 3-4 times a year with bloods. Okay. They say you only need to do it once a year. I don't believe in that. I monitor my guys probably 3 times a year in terms of bloods. And guys think when they come into me, oh, Martin, how's my PSA? How's my prostate blood test? I'll say, we'll get to that now. But the first one we're looking at is hematocrit. Okay. And mostly, once you keep your doses of testosterone in a fairly physiological range, i.e., you're just giving back what they didn't have, you're not going to run into too much trouble, mostly. But you've got to be watching it. And my point is, like, they're human. They could be dads. Okay, they could be mums too, the females too. And who's watching their hematocrit?
Yeah.
It isn't the guys that are giving them testosterone, is it? No. So we need to just think it a little bit differently. You know, if you're on heroin, you can get
methadone.
And you can come to me as a GP and I'd be very sympathetic to them and I'd want to help them. Okay. But what if you're on anabolic steroids? Maybe we just need to think about that a little bit.
Yeah, I know it is, because it's something that isn't addressed at all. Sure, it isn't publicly.
How many guys have you had on here on the pod that are taking anabolic steroids?
No, I only had a pharmacist who spoke about the addiction side of
it. But often we talk kind of not great terms about these people. It's not fair, I think.
And did they ever come off it? And then as a result of being off it and their testosterone maybe not getting back?
Yeah, I've had a few guys that have been using it recreationally and they've tried to come off it. You see, the problem is the longer you're on it and the higher the dose, super physiological doses, the less chance that your axis will kick in again and that you'll start making the on switches for your testes.
Okay.
And that's a problem. And then they're stuck on it.
Does it affect their erections if they're on it as well?
So if you think about it, right, the more testosterone you have, the more conversion of testosterone to other hormones you'll have, like things like dihydrotestosterone, estrogen. If you take too much of any hormone, you have problems with blood pressure and so on and so forth. So you can get downstream problems. And of course, you can get erectile dysfunction. Of course you can.
And can that be the reason why you see some men and they grow breasts as well in some instances?
Yeah, so we just said it, right? So you get conversion of testosterone to other things. So men need estrogen. Okay. So if I give a guy testosterone and I block off his conversion to estrogen, right, and I get his testosterone to a lovely level, do you know what his libido will be like? Shocking. Shocking. You need estrogen, but too much estrogen and you can get things like gynecomastia, of course, again, which is breast enlargement. So once you intervene with the hormone tree, okay, you can run into trouble and you've got to be used to what you're doing. You need to know what to look out for and you need to counsel guys correctly so that they're aware of the risks. Taking testosterone is not a no-risk zone. I'm a huge advocate for it. I came into it not knowing anything.
And are you one of the only clinics then that do it the way you do it? I know we've spoken about there, obviously you can get testosterone anywhere you want.
So there's loads of clinics out there now who look after men. But I would say we're one of the few clinics that will look after men from start to finish. Okay? If you come in and you have a problem with testosterone, I'm all over it. If you've got a problem with erections, I'm all over that too. But I'm not leaving it at that. I'm interested in your heart. Okay? And if you're on testosterone, I'm interested in monitoring you and keeping you at the right level. Okay? Not too high, not too low.
Are we a bit behind in Ireland though when it comes to testosterone therapy? Like in America, it seems to be, it's talked about a lot. It's all the rage.
Yeah, but you can overdo things, right? In the States, you'll often have these things called T clinics where you can just rock up, get an injection, in one door, out the other. They don't ask you any questions. They just ask you for the payment. That's not the kind of clinic we are. We're interested in men long term. Okay. And we're interested in prevention. And also
what's the outcome of you just being able to rock up and not being monitored as well?
Yeah. Well, that's they're businesses, but I wouldn't say they have much morals about them. Yeah.
Roid rage. Have you ever seen any of that?
God, I haven't a clue.
It's more the anabolic steroids, probably people that are abusing them, that if they're taking the testosterone, they, one guy, I don't know, he was a UFC fighter, he was injecting himself and he got into a rage and killed his family and they blamed the steroids that he was taking as a result of it.
Anything is possible. I mean, I'll always tell you when I don't know. I don't. Yeah. Although, I consent guys about anger with testosterone. I've never seen it. Never seen it. I have never seen it. Once I give testosterone and you are just replacing the amount that they didn't have. So let's say allergic reactions. We always worry about allergic reactions, but think about testosterone. So it's a hormone in your body from both males and females. I'm just giving them what their body's used to, but just returning it to a level that it wasn't at. It was at one stage, but just not now. Yeah.
Prostate.
Yeah, right.
Can we talk a little bit about that?
Yeah, we probably should, right? I think it's a big week. Eddie Jordan passed away, and I think anyone who's around my age, I'm in my mid-40s now, I think we'd kind of like Eddie. I think he was, I never knew Eddie, I don't know anything about him,
but you
kind of felt he was a guy that you could be proud of as being Irish. And I think he did, I know nothing about Formula One, but I felt very sad for him. Now, here's the thing, right? Eddie has passed away from prostate cancer, and I don't know Eddie's case, but let's talk about prostate cancer, and let's talk about prostates, and let's talk about the digital rectal exam, right? Now, how many guys put off going to see the doc for a prostate check because they know they might get an exam?
Yeah, I'd say loads of them.
Loads of them, right? So this is what they'll tell me. They'll say, geez, Martin, I'm sorry. Sorry for what? That you have to do that. Examine your prostate. I'm like, this is like me examining your hand.
It's like me sticking my finger up your nose. There's no difference. It's just...
I don't stick many fingers up the noses.
Okay. But... I'm trying to just say it's just another orifice for you, Martin.
For sure. So once you get a guy, okay, so I always examine, so I was taught how to examine the prostate in two positions, either men leaning over the couch or on the couch. No, I always think it's better on the couch. Okay. So I'll get them
lying down?
Yeah.
Okay.
So I'll get them to lie on their back, slip down their pants, their underwear. I'll cover them to be decent. Okay. I'll offer them a chaperone. Nobody goes for a chaperone. That's great. Okay. Then I'll say, right, do you know what?
I'll offer them some champagne.
I don't drink. I don't drink.
With a pint again, it's not doing them.
So I'll get them to turn onto their left-hand side. I'll get them to bring their knees right up into their chest. And then I'll press on their shoulder and I'll say, now this is what it's going to feel like. It's going to feel a little bit of cold from the KY jelly I'm going to use, and you're going to feel a little bit of pressure on your back passage. And all I want you to do is do the deep breathing that I'm going to get you to. And they'll be like, oh, geez, go on, Martin, do it fast, will you? And I'm like, no, just hang on, and we'll just do it nice and slowly. And I'll put a little bit of pressure on. I obviously have my gloves on, a little bit of KY jelly, and I'll just get them. Once you get them in the right position, it is not a deep exam. Once you get them in, breathing in and out, it relaxes the sphincters and it's just an in, out. And why do you feel the prostate? Why do you think?
See if it's enlarged.
Yeah, but that's the thing called BPH. So we'll get back to that, right? Okay, so it could be enlarged with cancer too, of course. And most people don't even know what cancer is. Cancer is just, we're all made of cells, okay? And our cells turn over, don't they? So I have a whole new set of cells in my mouth this week than I had about 2 or 3 weeks ago. Isn't that fantastic, right? But when your cells just build to be a different block and they don't die, that's what cancer is. Okay, so when I'm feeling the back of the prostate, I'm trying to feel, is it smooth, which it should be, or does it feel like a little bit like a golf ball? Okay, and if it feels like a golf ball, little ridges on it, I'm a little bit worried. How often do you think I feel that?
I wouldn't say very often.
Rare as hen's teeth. I have never seen hen's teeth. Okay, so it's a rare thing. Okay, so men put off going to see their GP to get a digital rectal exam, right? Because they don't want that invasive exam, okay? So I'll always say to guys, you know what? The most important thing here is that we do something for the prostate if you're worried about it. If doing the exam is just you can't get your head there, do you know what? I'll still do the blood test for them because it's important, okay? Does it give me all the information? No. 1 in 7 men will have a normal exam and a normal prostate blood test. You know what? That's it, of prostate cancer. But the risk of that being a clinically significant, a tiger rather than a pussycat, that's low. That's low. Okay. So prostate cancer is important. The longer you live, the bigger your risk of prostate cancer. That is just the way it is. If you live long enough, you'll get prostate cancer, but it probably won't kill you. The one you don't want to get is when you're a bit younger. And it's a tiger, not a pussycat. And that's why, you know, if you've got if you're a man and you're alive, you should get your prostate checked. And if you can't get your head around the fact that you need a prostate exam, because it is adding a little bit of knowledge, because if you're going to get prostate cancer, actually it is more likely to happen at the back of the prostate. And that's where you're feeling as a GP, okay? But at least get the blood test. It's not perfect. It is not, okay? But it's a starting point at least, okay? Now, we don't have a national screening service for prostate cancer in Ireland. Why do you think that is?
Money, funds.
Okay, right. But what if the tools we have to screen are crap?
Well, that could be a reason as well.
Yeah, so we're not there yet. The prostate blood test, thing called PSA, it is just not a good enough test to hang your hat on, right? Okay. The exam adds a little bit of merit to it, but it's still not good enough. But things are changing. A thing called an MRI of your prostate, we're probably not far away. There's newer blood tests coming, okay? So what we want to do is to be able to sort out the pussycats from the tigers. And if you've got a tiger, we want to pick it up early so that any cancer you have is in the prostate, but doesn't go elsewhere. When it goes elsewhere, that's called metastatic. And that's never a good word.
So the PSA test isn't amazing.
No.
We need better tests. Is that so? If someone gets an all clear from you giving them a digital exam and the PSA test.
So we're back to screening.
Right.
Nobody understands screening.
Yeah.
Right. So with screening of any part of your body or any disease, you're going to miss something. Mm-hmm. That is the very essence of screening. It's just not understood. But you're going to pick up loads as well. Okay, there'll be things like false positives and false negatives. So what I'm saying is the tools we have right now for a national screen for prostate aren't there. Okay. But that doesn't mean we don't use the tools that we do have. Okay. And the tools we have, examine the prostate. It does add a bit of merit. Certainly do the prostate exam. That's really important. But family history is important as well. Okay.
So if someone has a family history of prostate,
they should know their numbers.
Okay.
And they should be monitoring their numbers.
Okay.
And if you get a doubling of your number, maybe you should.
Okay.
Seek other avenues of looking at your prostate. And there's a non-invasive MRI now that can give you a thing called a PIRAD score, which is really helpful. PIRAD score 1 and 2, we're not worried about. 3, the radiologist is not so sure. 4, I'm a little bit suspicious. PIRAD 5, need to do a biopsy.
Okay.
Right.
And what are the symptoms that men might experience if they have prostate cancer? Okay.
So this is a big thing, right? So let's shimmy just a little. Okay. Most guys, when they have prostate symptoms, what are the symptoms?
Just going for the wee regularly. And
okay. Difficulty starting urination, difficulty stopping urination. Okay. And maybe going more at night. Okay. They are symptoms of a condition called BPH, benign prostatic hypertrophy. Now, what's the most important word in all of that?
Benign.
Why is that?
Oh, because it's actually all right. It's just...
So we now know there's some data to say that guys that have BPH symptoms, they actually are less likely to have prostate cancer. Okay? But that...
Really?
Yeah. So that is out there. However, right, prostate cancer, if it's going to come around, it generally can happen around the back of the prostate. Okay. But it isn't unknown to have symptoms like BPH. Okay. When you have prostate cancer. One of those is erectile dysfunction. Okay. All right. But for prostate cancer, I'm talking about, I am not saying that those that have BPH type symptoms couldn't have prostate cancer. I'm saying guys with BPH, a benign enlarged prostate, and they're having troublesome LUTS or lower urinary tract symptoms, we now think maybe they're less likely to have prostate cancer, and it's more likely we're treating actually BPH. Do you know what one of the treatments for BPH is? So there's a couple out there. There's things called finasteride. Now, I don't prescribe any finasteride. Okay, finasteride is used for lots of things for men. Male pattern baldness, okay, at a low dose, but it's used for BPH, benign prostatic hypertrophy. Finasteride is used to decrease dihydrotestosterone, which is DHT, which is made from testosterone, okay? And that's one of the things that drives prostate growth. But here's the thing with finasteride, 5% get this thing called post finasteride syndrome. Okay, where their mood dips, they get sexual dysfunction. And you know what happens? For some men, unfortunately, take away the finasteride, symptoms stay.
Oh, really?
Yeah.
What percentage of that?
So 5% will get post-finasteride syndrome.
Yeah.
So I don't prescribe that medication.
Okay.
There are other medications for this benign prostatic hypertrophy that are really helpful. We've talked about one of them already. Daily Cialis. Okay, so you can take daily Cialis, and I can be quite confident that it'll help your erections. It might even reverse some of the erectile function damage that led to your problem. It might lower your blood pressure, decrease the risk of dementia. And you know what? If you've got troublesome weeing problems, it's licensed for that too.
Really?
Imagine that.
Jesus.
So you now have a choice in BPH where you can give a guy who's got 5% chance of getting shocking symptoms.
Yeah.
Or a good chance that it might actually improve your erections well. Now, which do you think men will choose?
I don't know now. I don't know. That's a very tough question.
Well, I don't prescribe finasteride.
Okay.
So there you go.
Because finasteride was prescribed a lot years ago. When I first came out of college, probably, that was back in 2002.
Sure.
Huge. And then, so prescriptions for it have decreased a lot.
Yeah. And there are others. There are dutasteride. And back in the day when I worked in pharma, I was involved with dutasteride. That seems to be less effective, but finasteride seems to be just one of these medications that can cause problems.
And the finasteride causing the problem, can it cause the problem on the low dose for the hair growth?
It can.
It can.
It can.
And do you think people are properly counselled about that?
I don't prescribe it, so I don't know. I'm sure they are. I hope they are.
Yeah.
I hope they are.
I'm not so sure.
Probably not.
Yeah.
Yeah. Maybe they're just clicking it.
And with young lads.
Yeah.
With young lads on the hair loss stuff.
Okay. So let's talk about hair. Right.
Yeah.
How important do you think hair is for men?
I think it's actually hugely important.
Yeah, right. So I've been really, really lucky with my GP trainers. Right. Okay. Mary Taft, Joe Clark, Jim McShane, Nikki Casey. Amazing. But I remember going to a GP once who was working in the training practice I was in, saying, gee, this guy he's got male pattern baldness. And he's really upset by it. Worry about that. Dismissed it. And for a while, because you're quite, you can be molded a lot when you're a reg, and you're training and you think, oh yeah, that's not important. It's really important. For some men, hair loss is really important. Do you know one of the problems with taking testosterone?
Causes hair loss.
Male pattern baldness, and you've got to consent guys for that. Now, just back to the male pattern baldness area, would you think many guys go to Turkey for that?
Yes.
Right, yeah.
I do.
And some of the treatments here, some of the places are quite expensive.
Yeah.
Okay, but that's changing. Okay. That is
changing. It's changing.
Yeah. So
therapy must be getting involved, are they?
So
because they're bringing, bring like reduced. So their IVF packages and things like that are considerably cheaper than some of the other clinics. I had John Kennedy in, and he was just but they don't deviate from the plan. They have a standard for everyone, and that's the way they do it, and that's how they can keep the cost down, but that's how things don't go wrong. And he explained it all. It was a great session, actually. But
there is a gentleman I know who's setting up a clinic to try and give, again, he's trying to help. So he's trying to make it affordable for guys to get a thing called total hair restoration. But he's trying to get it more affordable, a good care package, but affordable. But back to my point. My point is it's important to guys.
Yeah.
And it'd be easy to dismiss it. I think I'd be okay if I lost my hair.
Would you? You've got a fine head. See,
my dad has a fine head.
You know what?
Hair.
That's all right for you to say because you have a fine head of hair. And my husband says the same. He's got a great mop. And he goes, I don't understand how men can be upset about their hair. I said, that's because you have a head of hair.
Fair point. But I think it's important to guys that it's important to. And I think as doctors, we shouldn't dismiss that.
Particularly if it happens at a younger age. Like if men are in their 20s or 30s and it's,
Yeah. So there are things called alopecia. Okay. And then there's male pattern baldness, which is kind of, I suppose, what we'd expect as men get older. But if that hits them younger, geez, that's really important, isn't it? Yeah. So I think we just need to be kind to all those guys out there.
Yeah.
Whether they're taking anabolic steroids or they're taking heroin or whatever they're taking.
Yeah.
Or if hair is important to them, geez, it is important to them.
Of course.
Yeah. So there you go.
Because like hair is hugely important to women. So when women go through cancer therapy and our hair falls out, it can be devastating.
Absolutely.
So if men have the same attachment to their hair, it's devastating for them when it's falling out. You know?
Yeah, then it's important, isn't it?
Yeah, 100%.
There you go.
And the treatments out there, like the Rogaines and the thises and that, they're not amazing.
They're helpful,
but they're not amazing for them. You know.
Yeah.
So
they're helpful.
Sometimes it's the hair transplants that are important.
Can be helpful. We talk about Peyronies before we finish.
We will, but I just want to ask you one more thing about testosterone, because you see, we go from one to the other, and you didn't let me get through all my questions, right?
Sorry, Laura.
You're a terrible man.
Shocking.
I just wanted to ask you about, do men, when they go on the testosterone therapy, find that their cognitive function improves, that their muscle mass improves?
Yeah,
they go and work out in the gym and be like, you know.
Yeah.
Tell me that, because there's all this thought. I'm massively into menopause.
Yeah.
And now we're talking about women being prescribed testosterone because, it's only licensed in low libido, but there's all of these other...
Is that?
Because they're not going to do the studies.
Who is sitting in a room deciding what's important?
Well, you worked in pharma. You know why.
But they
have to do the studies on them and show that actually...
You've got to remember, right? Guidelines and studies, they're all helpful, but they're not helpful to the patient in front of you. No. I do see females, and I think down the line, I think, to be quite honest with you, I think females are brilliant at advocating for themselves, right? I think the Joe Duffy eruption about menopause, I think that was fantastic.
Oh yeah, it was.
And you know what? It whipped a lot of us into shape in the old medical scene, you know? Mm-hmm. We're more knowledgeable now. We won't dismiss symptoms. I don't think I would have anyway, but part of that is I would not dismiss a female if she wanted testosterone. It's an important hormone.
Yeah.
Who's to say you can only get it if you've got low libido? I
know.
Let's just treat the patient in front of us, for God's sake.
Because women would take it and they say, some of them it doesn't help with their libido, but it's not a panacea. But some women will say they do feel an increase in energy. They do feel that their brain fog is lifted.
Yeah.
So I'm just wondering, does the same thing happen men with their cognition? Do they find
one of the common things that men present with is a thing called brain fog. Now, some GPs that might be listening to this, they'll roll their eyes like at that. But who am I to define what brain fog is? I'm just telling you what they present with. I had a guy, a high-level guy, he said, "Martin, I'm not thinking as clearly." Okay. Now, he was about in his late 50s. It'd be easy to jump to a thing called dementia, wouldn't it? Mm-hmm. Say, "Oh, geez, how's your short-term memory?" No, it's not that, Martin. It's just I'm not as sharp. Mm-hmm. I'm not as sharp. So you can call that brain fog. That guy, okay, we gave him some testosterone. He was low. All of that went away. Okay. Now, you might say, well, that's placebo. Could be. Yeah, absolutely. Of course it could be. Anything could be placebo. But when you see it consistently, maybe not.
Okay.
Yeah. So you've got to remember what testosterone does, okay? Testosterone gets converted to other things. I just talked about that. Gets converted to estrogen, gets converted to dihydrotestosterone. And you know what's important in neurocognition? Dihydrotestosterone. Really important.
Because there is a lot of talk out there now for like, could testosterone and HRT in general help to reduce Alzheimer's or dementia? Because we know that women are twice as likely to get it, and is the reason why they're all getting it. It can't be because they live longer, because they on average only live 4.5 years longer than men. So why are they all getting it? Could it be the fact that their hormones dip in midlife and that's as a result? Because that whole school of thought, Lisa Mosconi's doing loads of research in that area, and she's saying like Alzheimer's is not a disease of old age, it's a disease of midlife that presents in old age, because you have the 20 years of the fat building up. Yeah.
The time lag.
So all very interesting.
Yeah, and I don't know. I don't know. And it's okay to say you don't know.
It is okay to say you don't know.
I think as a doc, if you don't say you don't know a few times during the day, you really don't know.
Yeah.
So I don't know.
And I think sometimes...
But it's interesting.
Sometimes people can be afraid to say they don't know because they're afraid to seem like as if they're not knowledgeable, or they don't know their stuff.
There's loads of stuff I don't know.
And you can't just close a book on a patient as a result of that. Sometimes it's like you need to go to an expert, isn't that right?
There's been a huge change in medicine in Ireland, right? I would say. Patients have become more knowledgeable. Now, you can run away from that or you can embrace it. Mm-hmm. And I would say embrace it. So it's okay for a patient to know a little bit more than the doc in a situation. And all the doc needs to do is say, "Gee, right, I'm not so sure about that. Will we look into it together?" That's not a bad idea. Sure it's not.
Yeah.
But you know why it mightn't happen in general practice? And I work in GP, and there are fantastic GPs up and down the countryside, right? Is GP set up for preventative care? Is it?
Absolutely not.
It's changing, and in fairness, GPs are doing loads and loads for it. But it is an under-resourced service that is under pressure, and GPs are doing their best. They are doing their best.
In their 15-minute slots that they have.
Patients are living longer. They have probably greater demands on GPs. Patients have, and they should, right? Because their lives are really important, right? But they're getting more complex, and it's okay for GPs to say they don't know when they don't know, and it's okay for patients to say that's okay too. So work together.
Let's talk about that last thing that you wanted to talk about.
Peyronies, right. So
I don't know what you're talking about now.
Okay, so let's just talk about Peyronies. Okay, I think we've nearly talked about everything else that comes up in my clinic. But one of the things that might pop up is a thing called Peyronies, right? Where I'll say to a guy, now, how are your erections? Okay. And he'll say, well, and I'll go, tell me more. And he'll say, I have some erectile dysfunction.
Okay.
Okay. Or ED, or it's just not working right. I'll say, okay, tell me more. And he might say, there's a bend in my penis, doc. Okay. And I'll say, right. Tell me more about that. And he'll say, it's just not straight. And I'll say, well, it's normal to have a little bend left, right, up, down. That's fine. But you have a dramatic bend. I do. Right. Okay. So 9% of patients have Peyronie's disease. And you didn't know what it was. That's not a criticism of you. No. I went through medical school. I didn't know what it was. Okay. So it's where you get trauma. Now, sexist trauma. But what if you've got a little bit of erectile dysfunction? You're not as firm as you should have been. You're more likely to get trauma. Yeah, betcha. Right? The guys won't even know it. Okay. They'll get a little bit of damage. What happens with damage? You get scarring. When you get scarring, you get a plaque build up. And the next thing now, your penis that used to be fairly straight is now starting to curve up or to the side. Once it goes to 60%, they can't get penetration.
Oh yeah, of course.
Okay.
60-degree angle, you mean?
Yeah.
Jesus, yeah.
And how do you think guys feel about that?
Oh God.
So now it's a disfigurement, right?
Yeah.
And how likely are these guys to present to doctors? Even less likely. Okay. But there's great treatments out there. There is injections called Clostridium histolyticum. There's shockwave. We should talk about shockwave before we finish. And there are operations.
Okay.
Okay.
Operations to straighten it?
Yeah, to remove the plaque or to straighten the penis. Yeah, absolutely. Okay. But just try some other things first. Okay. And sometimes Peyronies, trauma, you'll get a little bit of deviation in the penis for a period of time. But 15% of those guys, it'll just resolve itself. So you need to not act too quickly, and you need to tell guys, this could get better. Let's just see how we go. All right. There are traction devices. Amazing. Loads of traction devices out there that can actually cause correction with a little bit of traction. Guys would apply it twice a day for 3 months.
I'm still getting over the fact that 9% of men will present to you with that.
No, I'm saying the prevalence of Peyronie's disease. Yeah. Jeez, I wish all 9% would present to me and we could do it. They don't present.
Okay.
What I'm trying to tell you is they are out there.
Wow.
And they are not presenting.
Yeah. Okay.
Because they think there's nothing that can be done.
God love them, yeah, okay.
God love them.
And what's the shock therapy?
Well, shockwave, really.
Shockwave to the penis?
Yeah, how painful do you think a shock could be to the penis?
Really sore.
Not painful at all.
Oh, really?
No pain.
Okay.
Thing called focal shockwave, right? Can be really helpful in Peyronies, in breaking down that plaque. Do you know what else it can be helpful for? Loads of things, okay? It can be helpful in erectile dysfunction, okay? Because once you cause a shock or focal shockwave, you're causing a little bit of trauma to the vessels. And do you know what happens when you get a little bit of trauma?
Yeah, just kind of replenishes
regeneration.
Itself, yeah.
So I've had shockwave done to my shoulder.
Okay.
Okay. Great response. Okay.
And that's what all that microneedling and that on the skin is done. That
all
the derms
trauma.
And that, yeah.
We're doing trauma in an effort to cause healing, neovascularization, and all the healing that comes with that.
And do you have the shockwave therapy in your clinic?
So we have links to it down the line. I'm sure we will. But it's what I would call literally emerging evidence. So we'll do the things that are good for guys with good evidence behind it. That's emerging evidence. Other things are like P shots and O shots and stem cells and all that. They're all emerging evidence and they're quite interesting. P shots are like PRP, so taking some blood, spinning it down, getting platelet-rich plasma where we think there might be some stem cells, and injecting that into the penis. Okay, do I do it? No, I don't, because I think it's got a little amount of evidence, but it's emerging. Okay.
They're doing the same with women, the O shot. They're
Exactly.
injecting the PRP into the clitoris.
Yeah. In a hope that you will get some stem cells in there. Now, what are stem cells?
They're growth factors. They are
the kind of beginning blocks. They can go anywhere they like. Okay. They can become anything they want to be. They're like your kids and our kids when we tell them you can be anything you want to be. Stem cells can be anything they want to be. So if they're around the penis and there is some damaged cells, they might become those damaged cells, but in a better form. That's the idea of stem cells. Okay. So PRP, we're too early in the evidence for that to say, maybe shockwaves is looking promising, but too early to say.
Okay.
But back to daily Cialis, remember, that's got loads of evidence, right? Loads and loads of evidence.
It's amazing, isn't it, how drugs develop, or they're developed for one thing and then they go off, they go off into the world and then they become so many other things.
Of course they do. But let's not forget diet, exercise, sleep, stress reduction. Now, what do I tell guys about stress reduction?
I'm sure you tell them that it's very important, but how do you tell them to manage their stress? Is what I want to know.
Guys need direction. So cold water is great. It's hard to get stressed when you're in cold water.
See, I would have thought that all this cold water therapy now that you see and these cold water tanks is a little bit of woo-woo.
I'd say it wouldn't add one day extra to your life, but it might decrease your stress. Might make you feel a little bit better. Try it.
Might be too cold.
Yeah, there you go.
But
maybe combine it with a bit of heat.
You do recommend cold water therapy?
Yeah.
And why? Is it just because you can't be stressed and you're freezing?
So think what it does, right? Causes a little bit of vasoconstriction and then vasodilation. It's a good thing. Okay. I think it does decrease your stress too. I think it's hard to be stressed about life matters when you're in very cold water. I think you've got to think about what's in front of you. The cold water.
It's like dealing with the bear in front of you, not the... Yeah, okay.
Yeah.
Right.
Let's talk about a bear, right? So reminds me of the psychogenic ED that we started talking about.
Yeah.
If you're in really stressful periods of your time in your life, like that guy you talked about who is trying to conceive with his wife and IVF, that's really stressful, isn't it? You're turning on your sympathetic nervous system. It's the same nervous system you need to run away from a bear that you just talked about, or a lion. And how important is it to get an erection when you're trying to run away from a lion? Not that important. So blood supply does not run to your penis when you are stressed. Okay? So stress-free environment is really important.
All interlinked, isn't it? But it's just, you see, I think the thing about it is that, we all know diet, sleep, exercise, stress, so important, but it's not sexy.
No, it's not.
It's not a quick fix. It involves a lot of work as well.
It does.
And like you say, men need a little bit of direction too, don't they?
They do. And that's
maybe
why
that cold water therapy is good because it's like you're giving them a thing to do rather than going, do a bit of breathing.
Males like to be tough, and the cold water is good. That's a toughly thing to do, So there you go.
Okay, I know we're finishing up soon. I do want to talk to you about the sex bots that you brought up.
Oh yeah.
See, I told you.
So you've great.
You would have forgotten that now.
I probably wouldn't have thought of it. Right. So I'm very privileged in my life. I get to go to the odd conference here and there.
Everyone was going to say, think that you were going to say, I'm very privileged. I have a sex bot at home.
I don't. And
tell us about the conference.
So anyway, I went to Amsterdam in November. My wife was very good to let me go, and went along. And one of the talks was by Marianne Brandon, a psychologist from the States, and it was about the future of relationships. And I was like, oh my God, what is this going to be about now? And I'm wondering, how can I dive out of this one?
Yeah.
I'm glad I stayed. So she talked about an experiment she did where she decided to get a boyfriend online. Now, her husband was in the audience. It wasn't Tinder she was going to. It was actually a bot. So she popped in all her information, what she likes, what she doesn't like, what food she likes, what hobbies she likes, what interests her, what turns her on, what doesn't turn her on, etc., etc., etc. Pops in, right? Also goes in your mobile number. And then you start getting messages from an AI-generated bot. And she said she knew it was a thought experiment. She knew it was a social experiment. But she started getting a little bit of an attachment to the bot because it's making her feel good. Now, the future of relationships might be, what if that bot was a sex doll, but the sex doll looked real? Okay. So now you've guys, are they going to really spruce themselves up on a Saturday night, head out to the club or go on Tinder and get rejected and all the problems that come? Or are they going to stay at home with a sex bot? Now that's a scary future, isn't it?
Yeah.
Wow.
It is, isn't it?
So no sex bots for me.
No.
No.
No, but like you say, and I suppose it's very topical at the minute with that series that's on Netflix called Adolescence, which is about a young
and I
boy.
haven't watched that yet.
Yeah, no, I watched it.
I won't be watching it now after what you've told me in terms of
it's
frightened you about.
It was just very thought provoking. It makes you realise what our young lads are being fed, and the whole essence of this program as well is about the fact it's just like any young lad, like your young lad or my young lad, and it's not someone that has serious issues or that has been brought up in an underprivileged family that there may be abuse in or anything like that.
Right.
It's a normal little boy.
Who
has fallen prey to
they're so vulnerable.
The bullshit that's fed to them online. So it's
so we need to talk to our kids, of course, about pornography. We need to talk to them about sex bots, maybe down the line if we need to, or the dangers around that. I'm not anti anything, right? I'm not anti pornography. I'm not anti anything. But I would see guys in the clinic who are consuming about 300 minutes of porn a week, and that has effects, right? And if you get back to the point where I say, what if a sex bot can somehow give a guy most of what he needs? Gee, that's just doesn't make sense. And look at all the data he might be giving to an IT firm. What could they do with that?
They're collecting all that data.
What could they do with that in terms of, blackmail or whatever? And I'm sure no IT company would be thinking of that, but what if it's hacked, I'm not an IT expert. I don't know. Just that talk in Amsterdam blew my mind.
Yeah.
I just thought sex dolls were like plastic things. I don't know what they were, but
you can actually make them into a semi-real human now in years to come.
So it's mad, isn't it?
It is.
Mad. Anyway, there you go.
Martin, what advice would you give young people today?
Right. So I heard a great phrase. I love watching The Apprentice with my kids, and I love watching Dragon's Den, right? So Joe Wicks is a guy I really like. I don't know Joe, but I like Joe. And Joe said a phrase on the show, and I said, geez, that's gas. That's a brilliant phrase. He said, if you're going to miss the bus, miss it running. Great phrase.
That is a great phrase.
Yeah. So that's the advice I'd give.
Always
go
for it.
Have a go.
Yeah.
And if you miss the bus, you can get the next one, but miss it running.
Yeah. No regrets, isn't that right?
Have a go. Have a go. I'm really privileged in my life. I think I'm really lucky. My kids are well. Michelle as well. I live in a world that's safe, right? Generally. Okay. I have stimulating work. Okay. That's really interesting. And I'm lucky that my health is good, right? It's one thing to be lucky. The other thing is to know you're lucky. I'm very lucky.
Even though you didn't make it as a hurler?
No, I thought I was good. I wasn't good enough. But it had a big effect on me. I thought I was good, but I wasn't good enough. But maybe I wouldn't have ended up where I am now if I did.
Yeah. Of course.
Yeah.
And what's the meaning of life?
Gee, I don't know that. I don't know. I think as a GP, I'm very privileged, but I get to see an awful lot of death. And you're put face to face with your mortality, I think, a lot. And that's very difficult. And I'll tell you what the normal phrase from guys mostly that I talk to when they're about to die, they don't fear death. That's a good thing, right? When they know death is coming, right? Sometimes death can be sudden, of course, but when they know it's coming. But if they've any regrets, what do you think their regrets are?
They didn't spend enough time with the people
They'll never say, I never finished that Excel spreadsheet. They'll never say that. But they'll say what you just said. And I worry sometimes about myself. I love my work. I love my family. But, you know, you have to work to provide. And as a guy, often I think we get that responsibility thing very good. So is the meaning of life? I don't know. I think it's the connections you make, the friendships you make, your family. Geez, that's really important if you're lucky enough to have one. And to be kind. I think that's it. And to try and somehow do your best, but Shani, not being too hard on yourself when it doesn't work out either.
Yeah.
Yeah. I think that's it. Isn't
Martin,
it?
what a pleasure.
Yeah,
what a pleasure.
Sound, yeah, really
Loads
enjoyed
of
it.
advice there.
Yeah, I enjoyed
Chunky.
it. Yeah.
I don't know how long we've been in here now.
Don't know. Long
2
enough.
hours, I'd say.
Jeez, they'll be bored out of their heads.
No, they won't. There's loads in there.
Yeah.
This is the podcast for a long walk, guys, okay?
All right, sound.
Thanks, Martin.